And so welcome everyone to our Fertility Network UK webinar this evening. I'm Kate from Fertility Network UK, and this evening we are joined by Professor Adam Balen, who you can just see coming into the picture there. He is one of the UK's leading experts on PCOS, polycystic ovary syndrome, and by Grace Dugdale, who's a nutritional scientist from Balen Fertility. We're going to be looking at weight and PCOS and answering some of your questions about that. Just a bit of housekeeping before we start. All our webinars are completely free to attend, but as a small charity, we rely on donations to be able to offer our free services. So if you do feel able to make a small donation to help us, we'd be really grateful for that. You can now text to donate, which is a really simple way to make a donation, and we suggest a donation of £3 to help towards the webinar. So if you want to do that, you can text FNUK3 to 70083 for a one-off donation of £3, or for any other amount, just text FNUK and then the number to 70085, and I will post that in the chat box once we get going. So if you want to do that, you will be able to find that there. And we have got some questions in advance, so we're going to start with them, but we'd also welcome your questions too. You can put them in the Q&A box and we'll get through as many of them as we can. Please be assured we won't read out your name, so all of the questions will be completely anonymous. And finally, we are recording this webinar, and you'll be able to find it on the webinars page on the Fertility Network UK website in the next few days. But for now, let's get on with the webinar, and welcome to Professor Adam Balen and Grace Dugdale, our guests who are giving up their time to be with us this evening. Adam, I wanted to start with you with a bit of a basic question, really, but what is PCOS?
So polycystic ovary syndrome, first of all, it's a common condition. It's the commonest hormonal condition to affect women, and affects probably 10 to 12% easily, possibly even more. It's a condition in which the ovaries have a greater than the average number of the little cystic structures that contain the eggs. We also call them follicles. So these are tiny, they're just a few millimeters across. We may come back to the terminology later and what these cysts actually mean, but essentially they are associated with an imbalance of the hormones that come from the ovaries, and that can cause a number of symptoms. With respect to fertility, the commonest problem is irregular periods, sometimes a complete absence of the menstrual cycle, and so either irregular or absent ovulation. But other hormonal effects that can influence other parts of the body include unwanted hair growth, often on the face, but other parts of the body as well, acne spots, and sometimes thinning of the hair on the head. And then there are some associations. So women with polycystic ovary syndrome often find it easy to gain weight, difficult to lose weight, and gaining weight certainly has a major impact on the symptoms and on our ability to treat the condition. And I know we'll come on and talk about that in a lot more detail.
So why does it have that impact on weight? What's actually going on?
Well, that's a big question. And there's a huge amount of research into this. So the way I look at it is actually some people find it easy to gain weight and have various genes and other factors that in their bodily makeup that make them, make it easy for them to gain weight. And if you then have polycystic ovaries, it makes the polycystic ovary syndrome worse. Men also can find it difficult to lose weight and easy to gain weight, but they don't have ovaries, so they don't have polycystic ovary syndrome, but will have similar metabolic problems such as developing high blood pressure and late onset or type 2 diabetes and other problems that will also affect men, but at a later age. If you have ovaries, then being overweight actually causes a greater disturbance at a younger age, because being overweight is associated with having high levels of insulin. Everyone will have heard of insulin, which is an important hormone that facilitates the utilization of sugar in the food that we eat. But some people are relatively resistant to insulin so that they don't utilize energy from food in an efficient way. The body then gets more and more resistant, the insulin levels go up, and insulin actually stimulates the ovaries to misbehave and stimulates the ovaries to overproduce testosterone and affects the development of the follicles. There are many factors that come into play. But there is also evidence that specifically women with polycystic ovary syndrome are inefficient at metabolizing energy from food. So after a meal, metabolic rate is disturbed. There can be differences in the way women with polycystic ovary syndrome absorb food, the gut microbiome, which I'm sure Grace will talk about, which is the body's balance of good and bad bacteria. All of these things can be disturbed in women with PCOS. So there are a number of additional factors that we see more prevalent in women with PCOS. And there are also big ethnic variations as well in how people metabolize. So we see a lot of PCOS, for example, in the South Asian population, who also have a preponderance for developing diabetes and metabolic problems, often at a lighter weight than white Caucasian women in the UK, for example. So there are big differences. Our genes have been with us for many, many generations, for many thousands of years, and there may be historical reasons why these differences have evolved as well, which maybe is a discussion for another day.
So, Grace, I wanted to ask you, there's quite a lot of discussion about the fact that people with PCOS can find it harder to lose weight. Is that actually true?
Yes, it is. It is. There are various components, as Adam described, so things like underlying insulin resistance. There can be certain genes that you're more likely to have if you have PCOS, that are associated with binge eating, for instance. And as Adam mentioned, the sort of gut microbiome. So there's lots of different layers. And then in conjunction with that, there are sort of genes that mean that you're less likely to burn calories as heat. And so when you sort of eat food and your sort of metabolic processes, heat is also produced as part of that. And so there are these sort of genotypes. So I think there's a lot of misinformation, particularly on social media, about sort of calories in, calories out, and that there's nothing else that matters. It's just you're just eating too much, and it's actually much more complicated than that. Obviously thyroid imbalances as well can make you more likely to gain weight if your thyroid is underactive. So it's much more complicated than even PCOS, obviously, and it's certainly not just a case of you need to eat less. So I think, if anybody's listening, please take heart in that. We know that it's difficult. We know that it's more difficult for you, and it's deeply unhelpful to have those messages sort of, bombarding you from every angle. And so trying to develop a sort of a healthy approach to weight loss and just healthy eating, and trying to sort of distance yourself from all of these messages that have been sort of ingrained in us for so long, I think is a good starting point.
Thanks. Someone's just asked if the webinar's being recorded. It is, and you will be able to watch it back later. Adam, I wanted to ask you, can you actually kind of reverse PCOS by losing weight?
You can certainly improve the symptoms, and some women do find that their periods become regular and will conceive naturally without assistance. I don't think PCOS ever goes away altogether. So somebody with PCOS is always going to have a tendency to develop symptoms, and they can change over time as well. But losing weight certainly can significantly improve the situation, and also make it much easier for us to offer treatments that will work. And weight reduction is not only about improving symptoms, but in the context of fertility, it's also about having a healthy pregnancy. And again, I'm sure Grace will talk all about this, because this is what we're all about. It's not only helping couples conceive, but also to have a healthy pregnancy, because being overweight or having inappropriate nutrition may be associated with an increased risk for miscarriage, an increased risk for certain congenital abnormalities in developing babies, and also problems throughout pregnancy, such as high blood pressure, diabetes, those sorts of things, that you can certainly significantly reduce by not only weight reduction, but appropriate nutritional balance.
We've had quite a few questions about different diets, and I know that people do sometimes try quite strict diets to kind of try to lose weight, for example, the keto diet. And I wonder, Grace, are they things that you would advise to people if they come to see you with PCOS wanting to lose weight?
Not really. I try to sort of recommend avoiding any kind of extreme diets, and there's lots of different sort of styles of eating that aren't always helpful. So the ketogenic diet, for instance, can often be lacking in sort of key vitamins and minerals that are needed to sort of help good health and help some of the underlying inflammatory status that can come with PCOS and the oxidative stress in the ovary and in the follicles and so on, where your eggs are developing. So that's often not helpful. And extensive calorie restriction and so on can also put a strain on the body if you're starting with suboptimal sort of nutrient status. So what can happen is when people have been trying to lose weight for a long time, they sort of go into a pattern of yo-yo dieting, restricting calories, therefore restricting nutrients. And then the starting point is even though you may be overweight, you're actually malnourished from a micronutrient point of view, so vitamins and minerals. And that's a very poor starting point for losing weight. And it's also a poor starting point for restricting things in your diet when you don't know what your starting point is, and unless you have expert advice. So there isn't a specific PCOS diet, but the starting point that I usually start with for people who don't have lots of advanced testing and so on is simply a Mediterranean style diet. So healthy fats, nuts, seeds, olive oil, fish, lots of vegetables, cooked tomatoes is a good one as well, and that's rich in lycopene, and when you cook tomatoes, that's an antioxidant that gives tomatoes a red color and it increases the bioavailability. So the Mediterranean diet is a really good starting place, and people will often have questions about reducing carbohydrate and so on. And so for some people, reducing carbohydrates a little bit can be beneficial, but you don't want to cut them out altogether. Most people need some carbohydrate for sort of energy, and that can also put the body under stress. So, but there are also gene variants that sort of dictate how susceptible you are to carbohydrate as well. So there are certain clock genes. So these are genes that are sort of involved in your sort of biological clock, your biorhythms, if you like. Variants that mean you are very sensitive to carbohydrate intake. So again, without extensive testing, what I would say is just try to listen to your body and pay attention. So some people know that if they eat a lot of carbs, they have a tendency to gain weight. And so that is probably your best clue for whether you want to sort of reduce carbohydrates or not. And also if you have an underlying insulin resistance, so if you have blood tests to show, and there's a blood test called the HbA1c that people that often use, if you know that you have impaired glucose tolerance, it can be helpful, particularly refined carbohydrates. I mean, we can talk in more detail, but certainly to start off with sort of extreme diets without expert guidance can often be unhelpful.
I think that's probably actually really quite reassuring for people, because I think there is sometimes a tendency to think that they ought to go on some kind of extreme diet, particularly if they're trying to get their BMI down for treatment. Adam, there's quite an interesting question here from someone who says that they've heard there are different types of PCOS: insulin resistance, post-pill PCOS, inflammatory PCOS, and adrenal PCOS. They're asking, is that correct? And do they have different impacts on weights? And how would you know which type you had?
This is the wild west of social media, isn't it? So you probably haven't even seen some of these.
Yeah, I mean, I think basically PCOS is a spectrum. I think the clue is in the word syndrome, so polycystic ovary syndrome. So syndrome basically is a collection of signs and symptoms that can differ quite a lot from person to person. And so some people have insulin resistance, but lots of women with polycystic ovary syndrome don't have insulin resistance and may be of normal weight without any metabolic problems. Having said that, some women with PCOS are normal weight and still have some insulin resistance. So there's quite a big range. For me, the way I look at it is it's important that you see a specialist, get appropriate investigations, and then as far as possible a sort of an individualized plan for management based upon the spectrum as it affects you. So I think there's a whole range. I mean, polycystic ovary syndrome is really common, and it will also, because it's common, it will also coexist with other conditions, some of which are common, some of which may not be so common. And so it's important that you have appropriate investigations to rule out other things. So, for example, thyroid problems are common, and many women with PCOS also have thyroid problems, but I don't believe one leads to the other or vice versa. They just occur together, but investigations need to be done. Some women with polycystic ovary syndrome experience quite troubling thinning of the hair on their head. That can be due to the overproduction of androgens. So the main androgen is testosterone, which comes from the ovaries and is often elevated in women with PCOS. But there are other reasons for problems with hair growth, which can be associated with nutrition. So being low in iron, for example, or having celiac disease, which is also quite a common condition, can also lead to similar symptoms. So it's very important that the doctor looking after you is in the know, so that you have thorough investigations and not just a tick box, yes, you've got PCOS, because there may be other things going on as well.
We've got quite an interesting question following on from what you were just mentioning about thyroid issues. Actually, it's someone asking if PCOS is often linked with hypothyroidism, saying they've recently commenced on levothyroxine and found that they have less of an appetite and have lost some weight. And will it help? Are those things linked?
Can I just say before we move on from the last point, because I think people had questions about the categories that you won't have seen, I don't think, in terms of on social media. So there are lots of categories that people talk about, adrenal and post-pill PCOS. Just to clarify, those aren't medical classifications. Sometimes people can find them helpful because they help explain that spectrum that Adam described, but they are not medical classifications at all, and they don't form part of the sort of any of the sort of medical classifications. So just to sort of,
that's really useful. Yeah. It's really useful to know. Thank you.
Yeah.
What about the thyroxine?
Well, if you're hypothyroid, so you've got an underactive thyroid gland, taking thyroxine is the treatment. Having an underactive thyroid gland is often associated with being overweight. So if you lose weight, that will improve things. But you're treating the underactive thyroid, not the polycystic ovary syndrome, but it will have a coexistent positive impact. And Grace may want to say something on it. Excuse me, whilst I cough. Iodine.
Oh yeah, so if you have, so again, this is, and a lot of the studies actually don't sort of account for this either. So there are lots of nutrients important for thyroid function. Iodine is the obvious one, and people are often low in iodine, and actually low iodine in itself is associated with things like reduced chance of success with IVF. So if you have any thyroid problems, there's a certain section of my patients who respond to nutrient interventions and their thyroid function can improve. So things like vitamin D, vitamin A, iron, and iodine and selenium is also a really important one. And it's really important to make sure that you have adequate levels of selenium before you start supplementing with iodine, because that can either cause or exacerbate thyroid problems, because your thyroid produces hormones, which is thyroxine as the hormone, and that's T4, and that's because it's got 4 iodine atoms in it, just to sort of explain that, and it gets converted into T3, and that's the form of thyroid hormone that's used by the cells that help control the energy metabolism of the cell. And that process needs selenium. So if you're pumping iodine into the thyroid gland without selenium there to support it, you can create thyroid autoimmunity, basically. So there's lots of layers of sort of awareness that when you're looking at these complex interaction of issues, and as Adam said, it's really important to have the appropriate medical investigation, so but in conjunction with that to consider the nutrient status and also your history. So if you've been dieting and restricting carbohydrates, if you don't eat fish and dairy, for instance, that's a classic combination for low iodine, and that can certainly sort of worsen thyroid function. So being aware of your history, what your symptoms are, having the appropriate medical investigations, and having a good sense of the appropriate sort of nutrients that are needed and are important for these different areas of your health, is really, really helpful.
Someone's just asked whether you can take these things with thyroid medication, and I think probably we can answer that in a bigger way about supplements more generally and when you should take them. I mean, Grace, do you recommend them to people? And if they want to take them, would it always be a good idea for them to discuss what they're taking with a doctor first?
Yeah, definitely. So thyroid, iodine, thyroid, the usual thyroid medication that most people are on is thyroxine, which is the thyroid hormone. So that gives you the iodine that your body needs, so that it's both the thyroid hormone thyroxine, but in that process of conversion it also releases iodine as it gets converted to T3 in that pathway. So you don't need to load in a lot of iodine. So, but what's helpful is things like selenium and making sure your iron levels are good. So the normal reference range for iron, what we look at is ferritin, which is the way iron is stored in the body. It's an iron sort of storage molecule, and the normal reference range is very broad, and if you're right at the bottom of that reference range, your iron levels will not be adequate. So you want to be sort of between 50 and 80 nanograms per litre for optimal things like thyroid function, for pregnancy, for fertility, and all of these things. And again, this is not usually looked at by GPs or fertility clinics, and it can also have an impact on your sort of thyroid function. So you just need to be a little bit careful before you take a lot of iodine, because some pregnancy multis contain very high levels of iodine, for instance, and if you're starting with a selenium deficiency, that can sometimes exacerbate things. So you do need to be careful.
Another question for you, Grace, actually, someone's asking, if you've got insulin resistant PCOS, what are the best carbs to eat, or should they just be cutting out carbs altogether?
So it's okay to eat some carbohydrate, but just make sure they're complex carbohydrates, so not the refined type. So avoid white bread, white pasta, white rice, refined sugar. Aim for organic if you can afford it. And I know that cost of food is pretty horrendous at the moment, but whole grain rice, wholemeal bread, and just keep an eye to whether you have any reaction to wheat and bread, and make sure you're screened for celiac disease if that's an issue for you, and wholemeal pasta rather than the white refined versions. And if you have potatoes, make sure you have the skin on. It's not bad to eat potatoes, try to avoid them every day, but make sure you keep the skin on. Jacket potatoes or boiled new potatoes with their skin on. So it's things like that can make a big difference. And also not eating them on their own, so eating them with some fat and protein together will help slow down it will dampen the spike of sugar in your blood as your body metabolizes the carbohydrates. So yeah, just and again, it's a case of your best judge is your response and how you feel, and that's why letting go of weight loss for a while and starting with just 3 meals a day, healthy Mediterranean diet, as your starting point. Try to make sure that you've got the key nutrients, get tested by your GP if you can. That's your starting point for weight loss, and it'll make everything else much easier. And then if you then start saying, okay, I'll reduce down my carbohydrate a little bit, you will notice if that doesn't make you feel good, if you're more likely to gain weight, if you have repeat blood tests and they're getting worse. So start to just really pay attention and be aware of your own body and your own body's response, because it is often very individual.
Another question relating to carbohydrates for you, Grace, which someone's just asked, is, are gluten-free pastas good? Should people be switching to gluten-free?
So there is no evidence that gluten is universally bad for everybody, and there's a lot of sort of misinformation. And I think that there are sort of two schools: people who say everybody should avoid gluten, and some people say, oh no, gluten, it's a myth, you don't need to worry about it. And neither is quite true. There's a nuance, and some people do have sensitivity to gluten, but also celiac disease very commonly goes undiagnosed, and people don't always have the traditional digestive symptoms or adverse reaction to wheat. So you need to be really aware of this. And
it's easy to test.
It's really easy to test for. If you have things like non-specific symptoms like fatigue, any dental health problems, which is often not understood, any issues with hair loss, these are often non-specific symptoms, and things like anxiety can go hand in hand with undiagnosed and unmanaged celiac disease. So always have an eye out to potential individual sensitivity or the potential for celiac disease, particularly if there are any history of digestive problems or celiac disease. So that nuance is really important. So for most people, gluten should be fine. There's some evidence to suggest that it may be a sort of gastrointestinal irritant. The jury is still out a little bit. But what you need to be really careful of is that you don't strip out gluten and not replace it with things like beans, pulses, organic brown rice, and so on, because then you can be lacking the appropriate fiber. If you want to assess whether you think you have a problem with gluten, you can do a dietary exclusion process where you're just excluding one food at a time. It's usually for standard sort of nutrition intervention, it's the normal recommendation is 2 weeks. But often, particularly when it comes to where you've got lots of different conditions colliding, like fertility and PCOS, I will often recommend a 12-week exclusion process, and then reintroduce and see whether you feel better excluding it, and then when you reintroduce, see whether you feel worse by reintroducing it. And that's again the best way to do it. And just one final thing, if you have a blood test for celiac disease, make sure that you've been eating gluten every day for 6 weeks, otherwise you can get a false negative.
Well, that's really useful to know. Thank you. Adam, we've had a few questions about metformin and whether people should be taking it, whether it helps with weight loss, whether it's suitable for anyone regardless of their weight. So what is the situation with metformin?
It's another big question. And we've done a lot of research on metformin. It's interesting, actually, whilst we're talking, we touched upon earlier the sort of the spectrum of PCOS, the diagnosis. I think it's might be helpful for everybody to know that there are some national and international guidelines, and I'm involved with them, actually, with writing them. And actually, I was on a webinar with some experts at the World Health Organization just 2 days ago, Monday evening, and we were talking about metformin and finalizing the global guidance on the use of metformin for PCOS. So it's quite topical. Excuse me. So metformin is a drug that is very effective in treating diabetes, type 2 diabetes. And because of the association between diabetes and metabolic problems with PCOS, it was thought maybe, we started our research, it was probably 30 years ago we started doing our research on metformin because it seemed logical that it may help. The bottom line is that if you have type 2 diabetes or insulin resistance, metformin may be of benefit if you've got PCOS. Some women with PCOS find that metformin kickstarts weight reduction, but it's not that effective in doing so. And the evidence for metformin in improving fertility is very weak. So metformin does not really help with fertility treatments, and so we're no longer routinely recommending it as a treatment either on its own or combined with other drugs for people with PCOS trying to get pregnant. So there is a role, but it's a relatively limited role. It is associated with gastrointestinal side effects, so flatulence, diarrhea, that sort of thing can be very troubling. And lots of women stop metformin because of the side effects. There is a slow release medication that you can take, and we usually start with a low dose and build up gradually. So it has a role, but it's limited.
We've got a question going right back to the sort of basics here, with someone asking, could you recommend how and where someone should see a specialist, someone who's seen their GP but doesn't know what the next step should be? So Adam, what should happen next?
So GPs obviously have got to deal with a huge range of medical problems, and not all will be tuned in with PCOS, unfortunately, even though it's very common. So if you've got PCOS and you feel you'd like to see somebody who's a bit better informed and to see a specialist, then I suggest you ask to be referred to your local gynecology clinic to see the local reproductive specialist. So in other words, somebody like myself. There are lots of specialists in hospitals who will deal with aspects of PCOS, so skin specialists if you've got a specific skin problem, or endocrinologists may deal with the hormone side, but I deal with the hormone side, and fertility specialists should be fairly clued up on the spectrum of the condition and how to properly manage it. So and you know, if you feel you're not getting anywhere with your GP, please ask to be referred to a fertility specialist.
Good advice there. And we've had quite a few questions around myo-inositol and alpha lipoic acid, lipoic. I knew I wouldn't pronounce it properly. Grace, you can pronounce them properly. But what are they, and can they be helpful with weight loss?
So interestingly, inositol is actually a sugar, interestingly. So it has a sort of role in the body for sort of various sort of cellular activities, including insulin signaling. And that's why there's interest in whether it's of help to improve symptoms of PCOS. Now, Adam will tell you he's, again, been involved in the guideline about the evidence is poor quality. Is that right? Isn't that right for overall in terms of inositol in PCOS?
For fertility.
But you know, there are some studies that demonstrate a benefit, and often the studies aren't always sort of looking for the right things. And so that might be part of the reason why we don't have sort of a clear answer. And certainly some women feel the benefits, and precisely because of that role in insulin signaling. So it doesn't do any harm. And the interest, the research is often in the mixture of different forms of inositol, say myo-inositol and d-chiro-inositol, and they are just simply different forms of the molecules. Myo-inositol is produced by the body. It's included in foods like cantaloupe melon, for instance, has got high levels of inositol, and the sum of that naturally produced myo-inositol is converted into the d-chiro. So it's a sort of it's replicating the physiological sort of levels, if you like. In terms of alpha lipoic acid, that is an antioxidant. So PCOS is associated with inflammation in the body and oxidative stress. So sort of how much to explain those terms really, but the terms that get banded around, but basically inflammation is usually a response to infection or injury, and it has a role in healing in the body. But when it's just produced at a low level, these inflammatory cytokines, it can sort of cause damage to tissue, and it can be a suboptimal environment for things like eggs to develop. So PCOS is associated with that. So alpha lipoic acid is an antioxidant that helps reduce oxidative stress and can have anti-inflammatory effects in the body. And there is some evidence to show, because women who have PCOS, their eggs develop in the follicles, that the follicular fluid has high levels of oxidative stress. So there's some evidence to show that things like alpha lipoic acid can improve the environment in which eggs develop and improve oocyte quality. So if you wanted to try those things, a combination of inositol, alpha lipoic acid, and coenzyme Q10 are things that can potentially help, but just be careful not to overdo it, because some women end up taking an awful lot of different things without any supervision, and it's very easy to sort of go the other way and take too much unless you really know what you're doing.
We've had a few questions about supplements, actually. I mean, Adam, can you take too many? Do you sometimes see people who you think are just taking a random selection of rather a lot of things, and might that be less than beneficial sometimes?
Well, Grace is probably the best person to answer that. But yes, I think you're right. People take lots and lots of supplements without necessarily knowing. And we haven't, I just realized, I'm looking over here, we haven't even mentioned, we should mention our book.
Yeah.
So the fertility book, which tries to demystify all of this. So
yeah,
Grace and I spent a long time writing this and looking at the evidence. And it's not only about PCOS, but it basically covers how to improve your general health and your reproductive health for women and men, actually, and we talk about all the different treatments as well. But I think it's very easy to go into, I don't know, a chemist or a health food shop, or even online, and just tick all the boxes and fill your basket with a whole load of things. And some of them can counteract each other as well. I mean, I think,
Sorry, do you want to add something, Grace?
Yeah, I mean, I think you can just spend an awful lot of money on supplements, and people can try a lot of different things without, it necessarily knowing the benefit and being sure of the evidence. And I think that the other thing to say is that there's some supplements that you should just be careful of if you've got things like thyroid function. So it does get quite complicated, and selenium is a really important one I've touched on, and that's one example of it's a sort of Goldilocks nutrient, where too little is bad and too much is bad as well. It can be toxic if you take too much of it, so you need just the right amount. And selenium is often included in like female antioxidant supplements, male fertility supplements, and so I sort of, see there are sort of two sides of the coin, people who are sort of lacking in nutrients, but other people who have been taking too much and actually have very high levels. So you do need to be careful. And also, things like zinc is a really common one, and that can be very beneficial, but it can drive down things like iron, it can drive down copper. And so, there's an interrelationship between all of these different nutrients. And so to just randomly take things without guidance, or from websites, from social media, or from other books where people who may have a sort of scientific background but don't work with patients and are recommending standardized supplement protocols, some very popular books, mentioning no names, it's potentially not much benefit. It will potentially cost you a lot of money, and even in some cases it can be detrimental. So you do have to be careful, and you need to have a sort of much broader awareness than just following these standardized sort of supplement protocols that people are sort of churning out.
Grace, if someone can't, go through the whole process of having individual tests and working out what their individual levels are for things, would you recommend a daily multivitamin? I mean, is that going to sort of cover a lot of what people might need?
It's probably better than trying to self-prescribe a lot of different things or follow sort of protocols when you haven't been tested and you're not getting expert guidance. So to start with, a good quality multivitamin. And the other thing that can have an impact that can go with PCOS, there's not necessarily any association, but just because if you're having any fertility problems, it can happen. And we also see this in men. It's problems metabolizing the B vitamins, and in particular folate. And so supplements that have folic acid, you can see people who've been supplementing but still have a folate deficiency because there are gene variants that impacts the efficiency of your body's ability to convert folic acid into the bioavailable form. So I tend to recommend multis that contain bioavailable folate rather than folic acid, and that fulfills the standard advice for folic acid supplementation for fertility and pregnancy. It's essentially the same nutrient, but it's just in a different form, and it just means that if you do have that gene variant, you're not going to be deficient in folate, despite supposedly ticking all the right boxes. So a good quality multivitamin. There's usually not enough calcium and magnesium in these vitamins because they're bulky molecules. So I tend to recommend a multi, an omega, and calcium and magnesium in the evening. You can also consider taking a probiotic, coenzyme Q10, and as I say, things like alpha lipoic acid and inositol. Just be careful with things like alpha lipoic acid, because there are some studies to show that can exacerbate a thyroid problem, and that's precisely the kind of nuance and detail that these standardized protocols in books and websites and social media don't properly factor in. So you don't want to trade one problem for another. You're much better taking a food first approach, having a healthy diet, and taking a much more basic supplement protocol, and then if you're still not getting anywhere, then try to get some expert advice. Than you're better spending a little bit of money on good advice than spending a lot of money on supplements forever and a day, not knowing really what you're doing.
That's a good point, actually, isn't it? Adam, we've got a couple of questions about PCOS and normal weight, and whether if you are of normal weight, you should stop exercising to improve your fertility or even gain weight. I mean, would that be the case? It's one person who says they haven't been responding to ovulation induction medication and has now been told by the clinic that they may need to gain weight or stop all exercise, which is the opposite of what they'd thought. I mean, is that something that you see sometimes?
Something I see quite a lot, because again, you can have polycystic ovaries and be underweight and sometimes the fact that you're not ovulating or not having periods may be associated with your weight. So you need to have appropriate nutrition in order to sustain a pregnancy. And if your weight drops, so if your body mass index, your BMI drops usually below 19, although everybody has slightly different cutoffs, then you don't have the nutrition to sustain a pregnancy, and that's the body's way of sort of, it shuts off and stops ovulating as a result. And you can still have that and have polycystic ovaries. One of the easiest ways actually is to do an ultrasound scan. And if you have an ultrasound scan and you're not having periods and you've got polycystic ovaries, and the endometrium, so your womb lining, if it's thick, it means you've got lots of estrogen in your circulation. But if the womb lining is thin, it suggests you're low in estrogen, and that usually occurs in women who are underweight. So it's an easy way that I use to actually determine whether it's the weight or the polycystic ovaries that's the main culprit in not having periods. So again, gaining weight, but as Grace would tell you, in a nutritionally healthy way, not may certainly be beneficial. And for some people, it can just tip the balance. And certainly if I'm concerned that somebody is undernourished with a low weight, even if they've got polycystic ovaries, I wouldn't start giving them medication to stimulate ovulation, because even if we can help them get pregnant, they're much more likely to have a miscarriage and problems with the pregnancy again because of the undernutrition.
Adam, do you ever recommend medication to help support losing weight or to kind of kickstart weight loss for people? Is that something you ever do in the clinic?
Not really, no. So there aren't really any drugs that really help. So some people use, or some people are prescribed orlistat, which helps inhibit absorption of fat from the diet. But if you're overeating fat, it works. So I'm not expressing myself very well, but basically orlistat works by inhibiting the absorption of fat that you shouldn't be eating anyway. So not that I'm saying you should restrict all fat, and Grace will tell you there are healthy fats, of course. So rather than prescribe orlistat, I would advise seeing an expert like Grace and making sure that you have appropriate fat in your diet. As I mentioned, metformin can kickstart weight reduction a little bit, but not very much. There are drugs, like some people may have heard of liraglutide, and there's a family of drugs that are used for the treatment of diabetes that are effective in achieving weight reduction in the context of PCOS. And I've been involved in quite a lot of work looking at these, but they're not able to be taken if you're trying to get pregnant. So that's the sort of the problem there. Some people who are extremely overweight may actually benefit from having gastric surgery, so a gastric band or bypass. But again, and that's if you have, very significant weight problems, and it can be very effective. But it's again important to ensure that you're metabolically and nutritionally stable before trying to conceive after such major surgery, because there's often a very rapid decline in weight and a big disturbance in nutrition. And if you then get pregnant at that time, that's not good for the pregnancy either.
Grace, I think this is one for you. Someone who says that they've lost 10% of their body weight, although they're still overweight, but they've reached a complete plateau for the last 2 months, not changing diet or lifestyle. It's exactly the same weight they've got to when they've tried to lose weight before. And this person asks, is that a known problem for PCOS? And is there a way to overcome that and to continue to lose weight?
So it's a really common problem. So there are sort of two components. You can get sort of metabolic adaptation, so your body adjusts to your reduced calorific intake. And also there's a theory where you have a metabolic set point where your body tries to restore you to your heaviest weight as a survival protection mechanism. And so, but I see this in patients as well. And so the best approach is start with, a healthy diet, food, supplements, multi and so on, so that you've got those bases covered. Because if you start being adequately nourished, that's your best starting point. And make sure that you then start a program of exercise. So if you're fatigued after exercise, that means that it's a stressor on the body. So you need to make sure you're sleeping well, following a healthy diet and so on, and build up gradually. But a program of exercise should be a combination of aerobic and weight-bearing exercise. So should be mainly walking and being active. So sitting down too much is very unhelpful and helps you, makes you more likely to gain and retain weight. So lots of walking every day, and 3 times a week, something that raises your heart rate. And then 3 times a week on other days, some weight-bearing exercises. So the thing that will help increase your metabolic rate is gaining muscle. So that's the one thing. So and then when you have a regular program of healthy diet and exercise, you can then consider things like intermittent fasting, and that may get around that metabolic adaptation where you're not, when you're constantly reducing calories day by day, your body adapts. If you go through periods of, say, 2 weeks on, 2 weeks off, your body is less likely to adapt to a lower sort of calorific set point. So it's worth trying that, but I've gone to the trouble of explaining that you need to get the foundations in place first, because if you're deficient in micronutrients, that's going to, you're going to crave more food, your body's going to sort of want to hold on to that food more to try and get the calories that it needs, and so your starting point should always make sure that you're adequately nourished from a micronutrient point of view as well. So those foundations are very, very important, and that's a healthy way to lose weight, and that means not avoiding fat. So all the sort of Weight Watchers and Slimming World and so on. So olive oil is very good. So every cell membrane needs fat to transport nutrients and everything else across the membrane. Your brain is mainly made up of fat. So, fat is very important in the diet, and particularly when you want to get pregnant. So having those healthy foundations are very important, and they're very important when you're losing weight, when you're thinking about pregnancy.
Adam, we've got a question here about when you're talking about irregular cycles with PCOS, can an irregular cycle just vary in length from month to month rather than actually be absent some months? So what actually do you mean when you're talking about irregular cycles?
That's a good question. And yes, it can be extremely variable from person to person and unpredictable. And I think that's a huge cause of distress as well. And the longer the interval between periods, then when a period occurs, it's often very heavy, can be painful and difficult to manage as well. So that's the other aspect of it, and that's because the endometrium, the womb lining, gets thicker and thicker, and that can cause problems with fertility as well. So we define a regular cycle as a cycle that can be anything between 23 to 35 days from the start of one period to the start of the next, but doesn't vary by more than a couple of days each month. So in other words, it could be 25, 25, 26, 27, and that's fine. Or it could be 28, 28, 29, 30, and that's fine as well. But if it's all over the place, and often with women with PCOS, it's longer than 35 days. So it could be 5 weeks, 6 weeks, 8 weeks, 3 months, and very unpredictable. And that can change over time, and fluctuations in weight can make a difference as well. Yes, it can be very debilitating and difficult. And the aim of treatment in the context of fertility is then to try and stimulate regular ovulation. And again, there are a number of ways to do that. Maybe I should just mention very briefly the ways that we do that, and that's all in our latest guidelines as well. So we've looked at all of the evidence. So lots of people will have heard of clomiphene or Clomid, which for many years was the traditional first-line treatment. These days we tend to use letrozole instead, which is also a tablet but works better than Clomid. So letrozole is a tablet you take for 5 days at the start of a cycle. And in an ideal world, it should be monitored initially with ultrasound to make sure you're getting a response. We start on a low dose. If that works, great. If it doesn't work, we increase the dose. If it's still not achieving ovulation, we move on to hormone injections as usually as the next line treatment. And if ovulation is occurring regularly, but a pregnancy isn't occurring, that's when you need to consider more intensive treatments such as IVF.
A few people have been asking about where they can find the guidance that you've been mentioning, Adam. Maybe if you could send us a link to your book and to the evidence, and we can put them both when we put the recording up so that people have access to that, because I think a couple of people have wanted to take some of that to their GP. And we've got an interesting one here. Why isn't PCOS considered when people have to lose weight for fertility treatment and reach a BMI of 30? I mean, is it considered differently to other patients in clinics, or just really not at all?
Not really, no. It's a good question. And actually, BMI is a crude measure of metabolic health.
Yeah.
And what the cutoff BMI of 30 is sort of historical, and I have to confess I'm kind of responsible partly for that, because I was involved in some of that early work. But more recent work, we've looked at different BMIs and different BMIs for different ethnic groups as well. But BMI is easy to measure because you just need a height and a weight, so that's easy to measure. But there are other more accurate ways of assessing somebody's metabolic health. And I've spent all my career just as I know you have, Kate, campaigning for better NHS funding for caring. And caring, I think, is the key word here, caring for people with a range of fertility problems, enabling them to lose weight, supporting people to have appropriate NHS funding. But because of limited resources, a cutoff was made, and a BMI of 30, I have to confess, is a little bit arbitrary, really. It would be nice if the NHS could relax its rules a bit.
I think it's also to sort of, focus on your health and your sort of and a healthy diet and your sort of nutrition, and also exercise, because the building muscle really does help. But the some of the research that looks at weight and fertility, for instance, it doesn't account for this. It doesn't account for whether that is starting with a place of yo-yo dieting, lots of unhealthy processed foods, or a fundamentally healthy diet with exercise and so on. So there's that sort of health at any size concept that isn't taken into account. Is something I'm interested in researching, actually, because I think that it's definitely something that we fail to look at, and it's also crucial when it comes to having a healthy pregnancy and a healthy baby. And I think I would really advise everybody to try and I know that there are time constraints and people who've been trying to conceive, and sometimes age is a factor and all of those things, and I completely understand that, I really do. But if you can allow yourself a period of just letting go of this need to lose weight and going back to the basics of the healthy diet, the healthy lifestyle, and actually really nurturing yourselves, because women can punish their bodies relentlessly, and it's just heartbreaking, actually. And so I really do sort of understand how difficult this is, but if you're able to give it that time, it can reap dividends. And ovarian function also responds to good nutrient status, healthy weight, exercise, and so on. And just going back to the irregular cycles and so on, I often see women with PCOS have a return of regular cycles by having sort of healthy lifestyle, healthy diet, yes, and weight loss often, but not always. So yeah, there's lots of general information on the book in terms of the general principles that you can start with in that respect.
Grace, it's a very topical question for you, I think, about what your opinions are on prebiotic foods like kefir and kimchi and probiotic supplements. I mean, what do you think about those things? Are they an important thing for people to consider?
So yeah, I mean, prebiotics, so there's just to differentiate, so prebiotic foods are things like fiber and polyphenols in vegetables. So they are the foods that help generate bacterial growth in the gut. Probiotics are things that actually have the bacteria in them already. So prebiotic foods, absolutely. So things like fiber, lots of colorful fruit and vegetables in the diet. Those are prebiotic foods that absolutely everybody should be included. So eat the rainbow, beans, pulses, whole grain rice, and so on. Absolutely. In terms of probiotics, there's lots of research going on. Probiotics foods are definitely worth including. You have to be careful. Things like kefir, if you buy it in a supermarket, make sure it's not laden with sugar and lots of additives. There's a good brand that I might go to, and I give them a free plug, no association with them whatsoever, but the Chuckling Gauche online has got a good sort of quite a pure sort of kefir. But the live natural yogurts, so things like Rachel's Organic, Yo Valley, again, that don't have anything in them, because often what can happen, the Actimel often have lots of sugar and sort of additives in them, and you can be sort of adding lots of unhealthy things in there. So yes, the probiotic foods. In terms of probiotic supplements, there are some ones that have been shown to have benefit as well. So a good generic one, and again, I've got no association with this company, but Proven Probiotics for pregnancy. It's not specifically a weight loss one, but it is one that has some research associated with it for pregnancy. So it's a generic one if you wanted to try one.
Thanks, that's really helpful advice. Adam, I'm aware we're kind of running out of time, and we've had quite a few questions about treatment options for people with PCOS. I mean, what is the sort of treatment pathway with PCOS? Would it be different depending on people's weight, and would the outcomes be different depending on weight too?
Yes. I mean, I sort of briefly went through the ovulation induction algorithm for people wanting to conceive. And if you're overweight, then we might need to use a higher dose of medication, basically. But just to sort of recap, it's lifestyle and attention to nutritional status has to be first line. For ovulation induction, it's letrozole, followed by hormone injections of FSH, so that's gonadotrophin treatment. Occasionally we use ovarian diathermy, also known as ovarian drilling. It's not used that much in the UK. It can help, but it's an invasive procedure. It requires a laparoscopy, so that's an operation. And it takes longer to get pregnant with ovarian diathermy as well, so it's not used so often. And as a last resort, IVF. So that's the sort of the fertility pathway. There are many other components of PCOS which we've touched upon. But if you're not wishing to conceive, it's important, for example, that you don't go long periods of time without menstruation, because the lining of the womb can become abnormally thickened. So that's when either the combined oral contraceptive pill, or taking progesterone on its own, or even a Mirena or similar type of progesterone releasing coil can be beneficial. Now, I saw a question in the chat about, then you have the Mirena out and you don't have any periods, or you take the pill and you don't have any periods. That would have been the case at that time in your life anyway. So having a Mirena or taking the pill is just masking what would have happened otherwise. I don't believe that there is a post-pill PCOS or problem. It can take a month or two to get back into your natural rhythm, but if you're not having periods, you wouldn't be having periods at that time in your life anyway. Treatments for some of the other debilitating features of PCOS, like the hair problems, are difficult to manage if you're trying to get pregnant, because the treatments are usually contraindicated or contraceptive. But if there's a problem with hair, particularly thinning of the hair on the head, then, as we said at the very beginning, make sure that your nutrition is checked as well.
Thank you both so much. We've had so many questions, and we've still got loads. We could stay here all night, but we promised to only take an hour of your time this evening. We will put that in the links with the recording, and also links to the guidance. But Adam and Grace, thank you both so much for joining us this evening. It's been really, really helpful. I've certainly learned a lot, and I'm sure everyone else has. Thank you all for joining us too. Just a reminder that if you do want support, we do have a weight loss group that you can join for peer support around weight loss. We've got lots of other groups as well. There are local groups and national groups for all kinds of different people. So do please join one of our groups. Do seek our support. We're your charity and we're here for you, and everything we offer is completely free of charge. So thank you very much. Thank you, Adam and Grace, and see you all again soon.
Bye. Thank you. Bye now.